Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to go through a paper. It was published June 8th, 2022. It is from the Journal of Osteopathic Medicine. The title is Cranial Osteopathic Techniques and Electroencephalogram EEG Alpha Power, a controlled crossover trial. Please excuse me, just got to clear my throat. Excuse me again. Okay. So we're going to read through this paper because there's a few things that are important in here. Overall, I think the paper has some general value, but there are some important things in here so that you can see explicit discussion of a concept called utility. Utility, especially in assessment, is the consideration, do we have the appropriate resources to actually do this? So do we have the time, the skills, or the money to do it? The overall term for that is the resources. So if we can't do it, then maybe we can't do it this way, we can do it another way. So we can make some trade-off type decisions. So there's a little bit of that in here that I was able to spot quickly, which is valuable because if you're looking at research, you're looking at the judgments of the researchers. So the term there is axiology, or the value-based judgments of the researchers. And some of that's going to be based on utility. Do we have the resources, the time, skill, or money? Or all three of them in some combination. So we'll read through this to give you some understanding of what that can look like. Okay. Excuse me. Jeez. Hopefully this doesn't kill me the whole damn time. Okay. To read. This is the introduction. Osteopathy in the cranial field, OCF, is a system of diagnosis and treatment that consists of a gentle manipulation of the cranial and or sacral regions and is aimed to restore the areas in dysfunction. The biophysiological mechanism supporting the OCF is still debated and remains largely anecdotal. So the researchers in good faith are noting what is understood at this point of publishing in 2022, but it would have been prior to that. They would have been developing the experiment and doing the work, but they were acknowledging that at the time, that the mechanism is debated. My note generally is that osteopathy does good work, but the stories are kind of nuts, and that is a much nicer way of saying what I say with some consistency. To read again, the treatment model for OCF, traditionally based on the so-called primary respiratory mechanism, PRM, relies on the anatomical and physiological link between the cranium and the sacrum, including bone joint movements, intrinsic brain and spine movements, and the fluctuations of cerebrospinous fluid. Osteopaths define the cranial rhythmic impulse as perceptible fluctuations in different areas of the body that are supposed to be related to the previously mentioned tissue and fluids, and that can be utilized as a diagnosis and treatment. However, the nature of such palpable phenomena is still unknown, and simultaneous palpatory findings at the head and sacrum show inconsistent results. So this goes into a model or a concept that I've spoken of before, whereby I've heard people say that science can't explain or test osteopathy. It can, you just don't like the answers. So the claims of osteopathy come from a place of a priori believing you know what is already happening. And within the scientific method, a priori is a problem, right? That which you are importing into the situation that you know from before, epistemologically, or the question of what can be known, how can it be known, and who can it be known by, if it was somebody telling you that it's working this way because anatomy, bro, then that a priori assumption has more problems. If it's been tested and we found a mechanism and we have some decent confidence in it and we've tested it in a variety of ways and our confidence has increased, maybe that's better to import as an explanation. But just because the anatomy's there doesn't mean it's doing the thing you think it's doing. And that is the constant challenge within the mechanistic claims of osteopathy, at least up until this point, because those claims are based on that a priori information or that thing that you're assuming and importing as if it's already true. And then when you test it, you test the claim and it doesn't hold up, then you say science can't explain osteopathy. It can. You just don't like the answers. However, if you start from a more open position to say, hey, there's some phenomena that's happening consistently when I do this thing, let's try to figure out what it might be. And that's sort of what these authors are trying to do. They're doing an EEG on the head to see if holding and doing a specific methodology at the sacrum and a specific methodology at the base of the head, what it does to the EEG of the head, right? You have to make some assumptions to buy that the EEG of the head is actually measuring the alpha band. I think it's the alpha band brainwaves. But you're at least measuring the exact thing that you say you're, not this thing you say you're measuring. The measurement is the same. It is EEG of the head. The EEG of the head, you would predict, or they are predicting, that if we measure the EEG of the head before and after both a cranial treatment and a sacral treatment, we should see change in the EEG of the head if this mechanism is related and continuous in the way that is claimed. So that's the basic experiment. Does this change the same way if I work on the head or if I work on the sacrum? Okay. To read again, some evidence suggests an OCF effect on several clinical conditions and physiological functions in adults as well as in children. However, data synthesis is inconclusive and highlighted both a poor reliability of diagnostic procedures and a methodologically low evidence about the effectiveness of OCF. Despite this, OCF is commonly provided to patients, animating the debate about its use. Continuing to read, some evidence about the physiological effects of OCF come from the study of compression of the fourth ventricle, CV4, a technique commonly utilized by OCF practitioners. CV4 seems to affect nervous system functions and results in lower sleep latency. Changes in blood flow velocity and cerebral tissue oxygenation to electrical brain activity modulation. However, the CV4 physiological mechanism is far from being uncovered. I'll stop there for just a moment. The location that CV4 is done and the size of the hands of the individuals who will do it often are going to be affecting a large amount of tissue that isn't necessarily the fourth ventricle, but it's in the region of it, superficial to it. There's a lot of musculature and a lot of vasculature. And generally what you're aiming for is the region of the occiput. Therefore, you are likely in the region of the superior nuchal line. There's just so much muscle there that you're probably having. It's at least possible to predict or hypothesize that you're having a diffuse effect and that maybe you would see something similar with cervical treatment to be tested, but you would want to compare against just cervical treatment to see if all of these things happen as well, because then maybe it's a change in the tissue environment that is doing these things and maybe not CV4 in and of itself, because you're going to be in contact with those muscles. You're not going to just be in contact out of continuity with only the occiput and therefore CV4. It's not going to happen. There's multiple layers there. So it may be valuable to investigate if a similar treatment time was done to the neck, what might happen, because that might elucidate or uncover some mechanisms that might be worth tracking down. To read again, a preliminary study of 10 subjects showed changes in alpha band power, BP, at the occipital area after CV4 treatment. The authors supposed that the CV4 could indirectly influence brain activity through its effect on the dynamics of CSF and in turn on a better cortical perfusion. This hypothesis led us to wonder if an OCF technique applied to the sacrum region could indirectly affect brain activity via the PRM. So alpha band brain activity, my understanding very superficially is that we're thinking about less random thoughts and maybe more focused thoughts. I think there's some things where there's more relaxation associated with it, whereby there's just less general activity going on. So there is maybe more narrow activity going on. It's not diffuse. So that it's a really rough understanding that I have of it now. But basically, it seems in quick terms to relate to both focus and relaxation, and that focus being a lack of variable thoughts, a lack of attentiveness to variable cortical areas, right? There's a variety of ways to explain it. As far as I've seen, and I'm stumbling with it a little bit, but again, I'm kind of rough with it, so I want that to be clear. But alpha band brain activity is a thing, and it seems to relate primarily to relaxation and focus. Now, focus, not necessarily hyperfocus, but more so just a lack of other brain activity going on. So yeah, they said, hey, if there is continuity in this system, the way that is claimed, and I do CV4 and I change the alpha band brain activity, maybe if I do a sacral approach, I'll change alpha band brain activity. Jeez. Anyways, we're going to go back to reading. An electroencephalogram EEG, a non-invasive, affordable method commonly utilized to record and analyze the brain's electrical activity, could be a useful tool for this purpose. EEG analysis based on frequency domains typically attributed to a specific brain state is characterized by high temporal resolution, allowing the identification of cortical excitability within fractions of a second after stimulus exposure. Like the precedent study on CV4, we analyzed the alpha rhythm, which is typically associated with relaxation, as well-established proxy of cortical excitability. So yeah, they did a more pointed job explaining it there. It's a proxy measurement, EEG, because it's superficial. There could be some other things impacting the reading. It doesn't mean it's not an accurate reading or it's an accurate proxy measurement. It just means that there could be some confounding stuff going on with that EEG activity. Just keep that in mind. It's probably relatively reliable in the interpretive step used, but the important thing that I want to point to as far as utility is concerned, they talk about it being affordable. EEG is an affordable way to check the brain activity with some reliability as a proxy measurement. That affordability is, do we have enough money to do this? So that is an axiological choice. The axiological choice is they value some form of effective use of available funds, aka money saving is another way to say that. To read again, to our knowledge, no studies have explored the potential effect of a sacral technique on brain activity as an indicator of a neurophysiological connection between the occiput and sacrum. The aim of the study was thus to explore the EEG alpha band activity during the application of ST sacral treatment compared to the CV4 application. Now, I'm just going to tell you ahead of time that the fallback position here is that anatomically these things are connected, right? So I don't know why you're even bothering to measure this. You know they're connected. The point here is to look at outcome effects of these things, not necessarily to look at connection. It is to look at connection, it's to judge connection within a claim. The claim is that the sacrum is connected to the brain through the dura in a way where you fix one end, you fix the other. And there may be some mechanical reality to that, but there may not be outcome reality to that depending on the claim. So if you're looking at measures of cortical excitability and relaxation, the alpha band brain power is a reasonable way to look at it, and you would want to see if the same thing happens. This is also not necessarily intended by these authors a test of, does it matter where you treat for your positive benefits to a patient? Here's the deal. Depending on your claim, depending on your construct, you are going to find that it does matter where you treat, and if you have a different construct, you will find it does not matter where you treat. It depends on the construct you're observing and measuring. So this argument that is going around that I have seen where it's a general effect from manual therapy with respect to the positive benefits, based on what's being measured, sure, there may be a general effect, but there's also more likely, depending on what you measure, a specific effect. And this one is also a test of that. So if I hold your butt, do I change your brain? Is the question here. Because I know on some level that if I hold your head, I change your brain. So if these are connected the same way, I should be able to hold your butt and change your brain because they're connected, bro, right? Because anatomy and stuff. I'm not going to read all of the methods. This is in Italy, which is cool. They do note the inclusion-exclusion criteria. They note sleep, don't use alcohol or coffee because the alcohol and coffee could impact the EEG readings. Right? So again, there's confounders. So depending on how you use the EEG, there's confounders. They controlled for known or attempted to control for known confounders. The study protocol was, so they got ethics, blah, 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 interventions. We'll do this. We'll read this quickly. 2 experienced osteopaths, MM and EA, each with more than 5 years of clinical experience, participated in the study. To align their interventions, they undertook a training session 1 week before the study. Each subject group distribution, which received a specific combination of interventions, was balanced for the 2 osteopaths. Descriptions of the techniques utilized are provided in Table 1. Is that Table 1? Compression of the fourth ventricle. Yeah. Head of the table. Blah, blah, blah. Whoa. Occipital squama. Yeah. Okay. Let's look at sacral technique. Subject was lying in the supine position while the osteopath positioned his dominant hand under the subject's sacrum. Then the osteopath established a point of balance according to the subject's CRI, cranial rhythmic impulse. That's going to be noted by the practitioner, facilitating his sacral extension until reaching the still point. Sham techniques. Sham interventions were carried out with the hands in the same positions of the corresponding active techniques by applying a non-therapeutic touch. So they didn't follow anything. They didn't pay attention. They just put their hands in the same place. So as a sham technique, that's fine because the people know they're getting touched. They don't necessarily know what's going on. I will say that experientially, there are times when cranial approaches are utilized and the person they are being performed on will have the general sensation and express it that they didn't know what was happening. It's all really gentle. So, evaluation procedure and data analysis. Yeah, no, I don't need to do that because they did fine. Yeah, they did fine. Statistical analysis, blah, blah, blah. Results. 40 healthy volunteers, mean age was 23.73, with standard deviation of 1.43 years, range 21 to 26 years, 16 males, 24 females were enrolled in the study and completed the study protocol. The AABP mean value and standard deviation for each time treatment are reported in Table 2, blah, blah, blah. Regarding the CV4, both the active and sham techniques resulted in a significantly increased AABP mean compared to the resting state. So whether you did CV4 or whether you just held their head, there was change in the EEG. The mean difference of CV4 compared to the resting state was 0.0927, whereas the mean difference between sham CV4 and the resting state was 1.955. Statistically significant, particular high increase in AABP magnitude was recorded during the post-CV4 compared to both the CV4 and post-sham CV4 application. A representative AABP dynamic during intervention and the effects of active techniques CV4 and ST on AABP compared to the related to the sham. Blah, 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 blah. Sorry, I'm doing a lot of blah, 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 blah. Whatever. Hopefully that doesn't piss you off too much. Yeah, so... Go into the discussion. Do I need to do that? I don't know if I'm going to do it that way. Okay, hold on. Thank you for bearing with me while I just scan through this. A lot of times I don't read the full papers before because what I would hope is that you're actually getting some ability to observe what it looks like to read through these things and try to understand them. But often, as a result of that, you'll have pauses as I do this. I will read the discussion and I'll probably do some blah, blah, blahs as I do it. As expected, the CV4 technique significantly increased the alpha power rhythm in the occipital area compared to the levels measured during the resting state. Such findings confirmed a preliminary evidence in which the alpha power level recorded in the post-CV4 increased. Although both the sham and active CV4 showed a minimal but statistically significant increase in alpha power level during the interventions compared to the resting state, the significant effect of CV4 with respect to the sham was registered during the post-intervention recording when the therapist's hands were removed from the subject's occiput after the perception of the so-called still point. During the application of the sacral treatment, no effect was observed for both the sham and active techniques during and after intervention, suggesting that the hypothesis of a neurophysiological link between the two techniques was inconsistent, at least over the occipital alpha rhythm. Okay, so they're doing a good job of saying the claim of outcome of relaxation from the sacral technique as measured through alpha band brain power is not there. The sacral treatment doesn't do something to the EEG as interpreted to measure alpha band brain power. So you got to understand, this is about the claim. It's not that something positive doesn't happen from that over-under sacral treatment looking for the still point. It's not that nothing happens. It's that it's not doing something to a measurement that is being chosen as by these people as representative of something in the brain, right? So the putative mechanisms of working on cerebral spinous fluid to then do something to the brain doesn't seem to be showing up because they're assuming that the change in alpha band brain power is suggesting something internal to the brain and its change of function. Okie dokie. To read again, the alpha rhythm is 8 to 13 hertz is the most prominent brain rhythm associated with the awake resting state with the eye closed. A large but not exhaustive body of evidence links the alpha rhythm to several neurocognitive functions, such as the visual attention and visual perception through top-down control and memory. However, its functional role is still controversial, and the mechanisms underlying its generation are not fully understood. Alpha oscillations in the visual cortex reflect a complex product of both thalamocortical and cortical-cortical interactions. The alpha rhythm is thus a complex brain signal whose functional relation with higher-order brain structures, including those underlying cognitive control, is still uncovered. In this scenario, we can only hypothesize provisional explanations about the functional effect of CV4 on the occipital alpha rhythm, which cannot apply to the sacral treatment. So, again, they're doing a good job with the attempt to interpret the data that they have present. To read again, it is commonly thought that in a resting state with the eyes closed, EEG rhythms reflect a condition of relative behavioral relaxation and of inhibition of the brain mechanisms underlying the interaction with the external stimuli, and more so, a state oriented to internal perception. In particular, the alpha rhythm modulation is closely linked to changes in the direction of attention regardless of the presence of visual sensory inputs. The CV4-related alpha power increase may thus suggest a condition of more internal attention and active inhibition of external sensory input. In support of this hypothesis is a recent study about the effect of OMT on the activation of specific brain interoception-related areas in patients with low back pain. To continue reading, C-tactile CT fibers could mediate the interoceptive effect via touch, including a state of well-being. The increase in alpha power level that we already observed during the hands-on period under both the sham and CV4 treatments could be intuitively associated with the touch effect, right? So that's a general effect. But if it was a general effect, you should also see it. If it's general, you should see it from the sacral treatment, one would assume. This hypothesis is supported by a study showing that cranial deep touch modulates the parasympathetic nervous systems as well as the interoceptive system. Fair enough. I would simply question, because there is still top-down control, if it's because of the inherent effects of touch to the head, or if it's because the person is thinking that it's nice to have their head touched. I'm not sure. So that would be something that could be tested in future investigation. To read again, instead, the specific increase observed during post-CV4 treatment hands-off period may result from a more complex mechanism indirectly activated by the CV4. This simplistic interpretation may also explain the null effect that we observed during the ST application, in which there was no skin-to-skin contact between the patient and operator. However, we cannot overlook that the few previous EEG studies on tactile simulation suggested a general alpha suppression in different scalp areas, especially in the somatosensory cortex. In particular, one study showed that touch, irrespective of CT optimal speed, decreases alpha activity, mainly in the frontal and central scalp areas, whereas no differences were recorded in the occipital area when the patient's eyes were closed. Although, in the contrast with our hypothesis, it should be noted that these results cannot discriminate the specific touch effect from the subject's alertness attention state during EEG alpha activity. That's saying the same thing that I was curious about with respect to the top-down control or the thinking. So the subject's alertness attention state. So the other findings may not be controlling for that is, I think, what they're more or less saying here. To read again, the results of our study apparently link the occipital EEG alpha increase to the 10-minute after the therapist perceived the still point and removed his hands from the patient's occiput. Two studies correlated the CRI with the Traub-Herring-Meyer oscillations. I've covered that before. That's not good. That's not good interpretation of data. The methods are flawed. I've talked about that in the past. The authors showed that the CV4 application results in an amplification of the 0.1 Hz low-frequency oscillations in blood flow. This effect is particularly evident 10 minutes after the still point was perceived. The 0.1 Hz component of THM oscillations is believed to depend on the sympathetic subsystem and of the baroreflex blood pressure regulation. The local increased blood flow that occurred during the post-CV4 probably activated baroreceptors, resulting in decreased cardiac sympathetic activity and increased vagal output to the heart. Yeah, those are assumptions. They're not saying that they're not assumptions. They're just going based on things that they've seen. They're trying to pull in information that might explain. To read again, the concomitant increased occipital alpha power that we observed is consistent with an overall physiological relaxed state, anecdotally described by osteopaths in response to the CB4. Moreover, a study provided interesting evidence on the causal coupling among neuronal activity, the microvascular hemodynamics, and blood supply oscillations in the 0.1 hertz frequency range. The results of the study suggested that the THM Traub-Herring-Meyer waves connected with blood pressure oscillations seem to be the primary cause of amplitude fluctuations in the central alpha and beta rhythms. This evidence could partially provide a mechanical explanation of the CB4 effect on the neuronal activity. However, it should be noted that the blood oxygen level dependent bold oscillations in the 0.1 hertz frequencies also have a neural origin, suggesting that such complex mechanisms may also be influenced by cerebral structures. Cerebral would often be conscious thinking, not exclusively, but could be. Yeah, the Traub-Herring-Meyer stuff, I believe it's just Meyer waves now. I think it's just Meyer waves now. And I think it is a very tenuous relationship. I think if my memory, I haven't sharpened up on this in a while, but my memory is that there's a general likely misunderstanding and that measuring this is not likely as accurate as they would want, at least with what they're doing. To read again, in our study design, the sacral treatment did not have an effect on the occipital alpha brain activity either during or after treatment. None of the previously mentioned functional hypotheses may apply to sacral treatment. Previous studies showing OMT effects on brain activity included cranial treatment and a general OMT approach addressing somatic dysfunctions. Their results supported the osteopathic concept that a whole body intervention may exert more evident central effects and in turn assume a more clinical significance differently from a single technique in healthy volunteers. However, this may explain only in part the null immediate effect of sacral treatment on occipital alpha brain activity. Moreover, if the sacral treatment may affect the cerebral hemodynamics or neuronal activity through the whole system of the PRM, we probably cannot monitor this effect through occipital alpha rhythm fluctuations. Likewise, the sacral treatment does not induce a more relaxed state. So again, they're being careful, they're being cautious. They're saying that we probably couldn't measure it, the hemodynamics or the movement of blood through the brain, if it was impacted by treatment of the sacrum. They're also noting that treating the sacrum didn't do anything to the relaxation as measured by the alpha brain or the alpha band brain activity. It doesn't mean the person doesn't feel more relaxed. You could apply the sacral only treatment and the person could report feeling more relaxed. There may be other measures of relaxation that may be more germane to that treatment, but with the measurement that they used, you don't see it. To read again, the clinical significance of an increased occipital alpha rhythm is limited if the signal is analyzed separately from other brain regions and other frequency signals. Several pathologies show altered alpha EEG patterns during spontaneous or event-related activity, mainly in neuropsychiatric disorders. Moreover, changes in alpha rhythms correlate to high-level sports performance in healthy athletes. Further studies that's probably the focus stuff. Further studies are needed to investigate possible alpha effects of the CB4 technique on this type of patient. For OCF practitioners, our results should have implications for clinical reasoning, with the awareness that OCF's tradition considers the cranium and sacrum a unity of structure and function, yet a technique to the sacrum may not induce the same neurophysiological effects to the one to the cranium. Yeah. Overall, I'm quite happy with the manner in which they went through their data, acknowledged things that did happen, attempted to pull in information to explain what they saw. I'm not confident in the Traub-Herring-Meyer wave stuff as explanatory, but I don't need to be confident for them to utilize it. I would have to go back through it and see what I think of it again upon further investigation or further consideration. I'll read their conclusions here. This study supported previous evidence that the osteopathic cranial technique CB4 produces immediate effects on occipital brain, alpha brain activity. So it is just touching their head, but it's the 10-minute mark after where you see CB4 actually showing something. Sacral treatment does not induce the same results, suggesting that OCF therapy should be investigated on a different biological basis. So it's a lot of words to properly explain with rigor and care when I say that it may be doing something, just not the thing you say it's doing. So osteopathy is doing something. It just may not be doing the thing that osteopathy says it's doing. The mechanistic claims have problems. The general conclusion from all of that, all those words, very fancy, very well written, pretty damn well done, as far as the manner in which the experiment was put together. I'm not sure I appreciate all of the discussion. Like I said, the trial-powering microwaves, I have a bit of an issue with that. But they were careful, and they were honest, and they were clear. But the big conclusion is osteopathy in the cranial field probably isn't doing what it says it's doing. It's doing something, just probably not what it says it's doing. So the thing that this does to me as an individual who has put forth the concept that osteopathy does good work, it's just the claims are kind of crazy, the stories are nuts, that further supports and increases my confidence in that general framework. The framework of osteopathy can't prove science. That's the claim that I've heard. This further increases my confidence in, yes, osteopathy can be explained by science. Osteopathic practitioners just don't like the answers as they stand because the claims that are made are not being supported by the investigations. So the claim that I already have in my head is not being supported. Therefore, clearly science doesn't understand. It's more likely that the claim that's in your head, the mechanistic explanation, doesn't hold enough value with respect to correlating to reality in the way that you think it does. Therefore, it could be causing you cognitive dissonance. It could be causing you challenges. Your work is still good. Your story might be doo-doo. If your work is good, keep doing the good work. Maybe reconsider the story. Maybe reconsider the mechanistic explanation. I am heartened. I feel good that I'm seeing more investigation of the basic mechanisms, and I'm seeing that there are concerns with the basic mechanisms. So I see some signal in the general research that people are actually looking at the base level, at the ground floor, the bedrock. What does this stuff actually do? They're starting from the range of previous claims and testing those claims. And when they don't come back the way that one would want, they're saying, well, what else might explain this? It sets up further experimentation down the road. So I'm seeing more basic science being done, which I like. I may not dig everything that's said, but I don't have to. I'm happy. I am very positive that it's being done. It's not being done everywhere. It's not trickling into the education. Educators still, as far as I can see, are far too confident in previous explanations and far too dismissive of the scientific method and the hypothetical deductive method. And then you get an over-reliance on people doing epidemiological stuff and systematic reviews. They're looking at research that was done in the past that wasn't done well, and then they tell you it wasn't done well, and then it's not helpful. My general contention remains that osteopathy as a profession is bad at science, the basic science, but it can be better. And I'm seeing signs that it is becoming better and that is showing up in identifiable literature. I really do want to say that I think the Journal of Osteopathic Medicine is doing a great job. They're consistent with their output. They are relatively well organized. They're exploring a variety of topics. And most of what I'm seeing, I like. Also, they're doing a pretty damn good job of making everything open access. One of the challenges with open access is usually the researcher has to pay a bunch of money to make it open access. So I'm not sure what their model is. I don't know the behind the scenes. Hopefully the researchers aren't having to pay a bunch of money to make it open access. Hopefully that's just the way that the journal does it. I think that's the way the Journal of Osteopathic Medicine does it, is they have a budget to make things open access. Not sure. I hope that's it, because that would be awesome. But generally, the Journal of Osteopathic Medicine seems to be doing a pretty good job on the basic science level. Not everything's awesome, but I'm seeing really positive signaling. So the big deal here, the big takeaway, if you've listened this far, is that touching somebody's head does something to the EEG in the head. Doing CV4 does something to the EEG in the head in the occipital region while it's being done, and it goes up about 10 minutes after. Whereas if you just touch the area, it does something to the EEG while you're touching it, but not after. If you touch the sacrum and do a standard sacral treatment within, say, a cranial method, it does nothing to the EEG in the occipital region. So the connection, the neurophysiological connection, doesn't show up in that measurement. It doesn't mean there's no neurophysiological connection. It just means it doesn't show up in that measurement. There may be another measurement that it will show up in. We would have to figure out what that would be. I'm not sure it's going to show up. If it does, cool. If it doesn't, also cool. Keep in mind, the patient may have a positive outcome that doesn't show up in the measurements that we're looking at. The work is good. You're doing good work. Your story probably sucks. So if you've listened this far, thank you for listening. Hopefully you've learned something, and we will talk again soon.